something that you unfortunately don't see much in our hospital. But say tomorrow you are the person who's going to take care of a marathon. Okay, you're going to take care of a marathon. Okay, it's bound to happen sometime or the other in your life. You will be said that part of the hospital you're going to go to take care of the Tata Marathon. And at that time, you are responsible for taking care of all the marathoners that are coming to you. It is at that time that you should be aware of what heat stroke and exertion in heat stroke means. Okay, so there is heat exhaustion and heat stroke. Okay, now heat exhaustion is just you're tired, you're dehydrated and you're tired. That is heat exhaustion. Okay, whereas heat stroke is completely a different entity. Okay, so when you say heat stroke, there is a completely different entity. So what is the difference between a heat? If I want to ask you, what is the difference between a heat stroke, okay, and fever?
Thermoregulatory mechanism.
Yeah. So Ruchika, any idea? So what she says is this is a problem with the thermoregulatory mechanism. It is a problem with the hypothalamus. Something has gone wrong there. Okay, something has gone wrong there, and that is the reason that what happens different from a fever. What happens different from a fever? When will you say that this is not just because see, you are not going to have this patient with a classical history of coming from a marathon and then lying down in your ICU. That is not going to occur. What you are going to get is a patient who some days ago, say for example, was an antipsychotic, okay, and then this patient this patient was alone at home, okay, and he has come to the hospital with a temperature of 105, or it's a patient who was at home without an air conditioner, without a fan, and there is a heat wave happening, okay, and then this patient comes to you. So you should be able to diagnose the difference between a regular fever versus a heat stroke, which very effectively Sachin has explained about what this heat stroke. So what did you hear? What is the difference? Ashok.
In heat stroke is also thermoregulatory mechanisms.
That is gone. So clinically, what do you see different? Clinically, what do you see different?
High grade fever.
So we cannot just say high grade fever. That is part of sepsis. So what do you understand by what is the difference between the pyrexia that you see here and otherwise? What could be the few points that would tell you, oh, this is a heat stroke?
Antipyretic will not work.
Antipyretic will not work. Importantly, you give an antipyretic, it will not work. You give first thing. What about the range of fever?
Range of fever will be more than.
How much would be it? More than
140.
More than 40 degrees. It has to be more than 40 degrees. Okay, the temperature has to be more than. So you cannot look at a patient who's 38.9 and you say that this is heat stroke. So it has to be a more than 101 degrees. So you say more than 40 degrees, 104 degrees. Sorry, 104 degrees. So when you say 104 degrees, that is when you will call it as a heat stroke. Okay, the first thing is the temperature has to be more than 104 degrees. Okay, there cannot be a response to an antipyretic. If there is a response to an antipyretic, this is not heat stroke. This is something beyond a heat stroke. Alright, board the language. Board the. Understand, beyond a table fever. Then what is the second thing you get? You have to get some neurological manifestations. Okay, an altered sensorium. Okay, an ataxia,
seizure,
a seizure. There will be something like that will be there. You'll have either an ataxia, you will have a seizure, or you'll have something like an altered mental status that will come. You can't walk, or a seizure, an altered mental status. So you must understand, you must think very hard, because this could be just sepsis causing a seizure. This could be meningoencephalitis causing a seizure with a high temperature. You understand? It becomes, so all these are under an umbrella term called as heat stroke. All this thing comes under an umbrella term called as heat stroke. Okay, so the sine qua non of that is the temperature being more than 104 degrees. You are having some altered mental status and there is really no response to an antibiotic. Clear? Am I clear till now? Heat stroke? Okay. Now, when I say temperature more than 104 degrees, means this patient will, because of the temperature being so high, these patients have got multiple manifestations which include. What would be the difference between heat exhaustion and heat stroke? So, heat stroke itself will have two parts. Okay, let's not put heat exhaustion as a part of it. Let's take heat stroke, having exertional heat stroke and non-exertional heat stroke. Okay, let's just finish that. The difference between heat stroke and heat exhaustion is very different. The difference between heat stroke and heat exhaustion is what? What would be the difference? In heat exhaustion, if you're going to run a marathon, you come down, you're going to be sweating. If you run a marathon, you're going to be sweating. So in heat exhaustion, you will have sweating. You will not have neurological manifestations. You will just be tired. You might be a little bit dehydrated. Okay, that's how you're going to see in heat exhaustion. Whereas in heat stroke, you're going to have dry skin. Absolutely dry skin. There is no sweating happening. There is no sweating happening. Absolutely no sweating happening. There is altered mental status. So that is the difference between heat exhaustion and heat stroke. Generally, a heat exhaustion will have a clear-cut history. It will have a history that I was walking about, I didn't get a bus and I've been walking for the last 2 hours, or I have run a marathon and that's why I've had this, or I didn't have an umbrella and I walked about in the sun. That's heat exhaustion. Patient comes tired, absolutely sweating, and you know that pulse is racing fast, he's got hypovolemic, you need to give some fluids. Right? Whereas heat stroke, we may not have a history because it has got various reasons why you get a heat stroke. For example, it could be just a neurological manifestation of a drug that you've given. Like for example, some days ago, patient was on a serotonergic drug. It's been started yesterday. For example, linezolid. Okay, you started linezolid. Okay, or you started some kind of antipsychotic over there. Okay, the next day patient will have high fever, altered mental status and all these things. This is a heat stroke developed because of a drug. It's a manifestation called as serotonin syndrome. At the end of the day, the physiology remains heat stroke. Okay, similarly, if the patient is on an anticholinergic medicine that has been started a while ago, what does anticholinergic toxicity cause or a change may cause? Neuroleptic malignant syndrome. So a couple of days later, that will take some time. When you give an anticholinergic drug and see after some week or week and a half, you might find this patient coming in. The history taking is so important that he'll say, 1 week back my psychiatrist has changed my medicine. And 1 week later patient gets a fever that is 104 degree temperature. 104. You should start thinking what this is all about. Okay, so that is called neuroleptic malignant syndrome. Okay, serotonergic syndrome, neuroleptic malignant syndrome. So the other possibilities are something called malignant hypothermia. That means you give a certain drug, okay, like scoline, okay, and this patient may have a sudden increase in temperature to 41 degrees, 40 and 104 degrees temperature, okay, with rigidity that comes in. So there's a difference between malignant hypothermia and this. There is the rigidity that comes in, whereas here in actual heat stroke you will probably have clonus and hyperreflexia. You understand? Clear on this? So neuroleptic similar, that's the same difference between serotonin syndrome and neuroleptic malignant syndrome also. Okay. Now, so and then that's why you have an exertional variety of heat stroke and a non-exertional variety of heat stroke. By exerting also you can go to a heat stroke level where you have altered mental status and all those things. Whereas non-exertion also, for example, there's a heat wave sitting at home, no AC, that is non-exertional heat stroke. Are you understanding? So there are various reasons why you can have, which can be drug induced, which can be disease like meningoencephalitis. Sepsis itself can cause a very high temperature, may cause other problems. You understand? But there are a few things that may come in because of the heat stroke. The first thing that may come in is a seizure. Okay, now how do you it's very important to control these seizures. Why is it important to control these seizures? Because the more they seize, the more it is difficult to maintain them. Okay, they are very agitated. Heat stroke patients are generally not drowsy, they are agitated. So now the question comes as how do I manage this particular patient of agitation? Okay, so you might think I will tie him up. No, in fact, if you tie him up, there will probably be more production of heat. There will be more production of heat. So the restraints are usually pharmacological. So you may want to use benzodiazepines, you may want to use ketamines. You understand? So it's a difficult proposition how to calm down an agitated patient. Clear? It's a difficult proposition how to calm down an agitated patient. The second thing these patients may develop is a liver cell failure, an acute fulminant liver cell failure. I have seen one patient. Okay, acute fulminant liver cell failure that comes after a heat stroke. Now, if you ask anybody what is the etiology of this, there are theories behind it, but no reason to say that acute fulminant. So, if somebody asks what is the cause of acute fulminant hepatic failure, we don't know what is the cause. Nobody knows what is the cause of an acute fulminant hepatic failure. If this fulminant hepatic failure means SGOT, SGPTs will be very high, something like ischemic hepatitis. So there is a possibility, there is a distinct possibility that splanchnic circulation is reducing because most of the blood is going towards the periphery in order to evaporate the heat. You're understanding? So this might be one of the cause of ischemic hepatitis, or there may be microthrombosis being formed, which is causing finally DIC. Okay, finally DIC. So there is a possibility of fulminant hepatic failure that comes into these patients. That is why you have to monitor the liver function test of these particular patients. The other thing that occurs is because of the extreme amount of muscle rigidity that they are getting, they might form rhabdomyolysis, as you rightly said. Rhabdomyolysis itself will be something that can be problematic for us in the future whenever we have a heat stroke patient. So fortunately, it is very easy to cool down a patient versus re-warm a patient. That basic thing you must understand, that cooling down a patient is much more faster than re-warming the patient. Can anyone tell me why is that so? Why is that so? And why is that important for you to know this? See, it's important for you to, first of all, why is that so? Why is that so? Because of the fact that what is the gradient between the fluid and the temperature? In this heat stroke, the temperature is say 40 degrees. And what is your the temperature is 40 degrees and the fluid is 4 degrees. So what is the gradient? 4 minus 40. 4 minus 40. कितना हो गया?
Minus
36 degrees का temperature. If your fluid is 4 degrees and your this is 40 degrees, 4 minus 40 is 36 degrees का gradient है. तो वो जल्दी ज़्यादा नीचे चला जाएगा. But if you are going to re-warm, say you are at 32 degrees, and from 32 degrees you want to get it to 38 degrees. Okay. Again, now here the gradient is 32 minus. You're going to warm the fluid. Maybe you can make it you can't make it too warm. So it may be 38, maybe 40, the warm fluid. So 40 minus 38 is barely around 2 or 3 degrees. So the re-warming becomes very important. Becomes difficult. Are you understanding? Because gradient is not there. Okay, you understand? So what does this mean to you? What does this mean? That if you are going to cool down your patient, there is going to be an overshoot. There may be an overshoot. That means if you are trying to cool at 35, it might go to 32. If you are trying to cool to 34, it might go to 31. And then rewarming will become very difficult. And you would have noticed it very often. You have patients of hypothermia and cardiac arrest, and then you want to rewarm them. Rewarming becomes a pain, but cooling becomes much fast. That's why as a bedside physician, what you must understand is, oh, where am I? Am I at 36? Am I at 35? Am I at 34? What is happening? I need to stop my cooling right now. Otherwise, I will overshoot, and once I overshoot, rewarming becomes very, very difficult. You're understanding? Fortunately, cooling works beautifully for us. So heat stroke can be managed much more easier. Are you understanding? Heat stroke can be managed much more easier. Clear? So you understand now. So if you're going to drop the temperature, it's very important that you don't drop it excessively. It doesn't go down too fast. Alright, now we are expecting a drop of temperature by say 0.5 to 0.2 degrees or something, 1 degree per hour. You want to reach where in a heat stroke? From 41 I want to reach 38. I don't want to make it 37. From 41 I want to reach it to 38 degrees. So what do I do? What is the most effective method in these cases? If I want to reduce my temperature, what is the most effective method? If somebody asks you that I want to induce hypothermia, and what is the most effective method in these particular cases? So let's take the example of a patient who comes from, was at home and develops a heat stroke, comes to you with altered mental status, is unable to actually talk to you also because completely altered the patient is. You have seen the temperature, you recorded it as 107 degrees temperature. You have recorded a temperature of 107 degrees. This patient's blood pressure is around 90. What do I do with this particular patient? And I know that this patient now, for all practical purposes, is in a heat stroke. That's why his temperatures are very high. He's in altered mental status. What do I do here? What do I do here? Come on quickly. So there are 3-4 methods of cooling, and I think the best method for cooling would be what, Sachin?
External fan.
External
fanning.
External cooling fan.
No, so the most effective method, external cooling, I'll tell you what's the difference between. So when you say cooling, that is when you say evaporative cooling, or for that matter conductive cooling, or for that matter radiative cooling, okay, all the different kinds of cooling. The best cooling method would be ice immersion. The best cooling method, ice immersion. That means there is a bathtub filled with ice, and the patient lies on that, the cooling becomes very, very fast. Okay, it is so fast that it goes at least 0.2 degrees per minute. It goes at 0.2 degrees per minute. You're understanding? 0.2 degrees per minute. So that's very fast. If you say 0.2 degrees per minute means in a span of around 5 to 8 minutes, I am 1 degree down. Are you understanding? I'm 1 degree down. So it's the fastest method of cooling. Okay, 0.2 degree. That's why an ice pack makes a lot of sense in patients. Okay, so in marathon situations, they have these kept for ice immersion. The second method, if you don't have ice immersion, is what? Is body bag with ice. So you have a body bag that we have in COVID. So body bags, those plastic bags, okay, that we used to pack our patients when they were dead.
Yeah.
Okay, so those plastic bags are called as body bags. Okay, you have these body bag. Put the body bag, fill it with ice. That's again the faster method to do it. 0.1 again, 0.2 degrees per minute of cooling you will get. Okay, whereas if you don't have both of these, okay, the third method of cooling is kind of conductive or evaporative, combination of conductive cooling and evaporative cooling. Okay, which we call as you take your patient is lying down over there, and then you take a water that is lukewarm. You can't have a water that is cold. A water that is lukewarm. A lukewarm water you spray in the vicinity of that particular patient, ensuring that the humidity is not more than 70%. If the humidity is more than 70%, this is not going to work. So you spray over there and keep a fan. So it will actually evaporate the heat. Okay, because it's lukewarm. Okay, lukewarm. You can't have it to be cold. It is not going to evaporate anything if it is cold. Okay, it has to be lukewarm. And then with that, it will probably go. The fan will take it away. Okay, so lukewarm spraying of water in the air with a fan will probably help to dissipate heat much faster. So this is not as convenient as it is for this. So here it will be somewhere around 0.1 degrees. So why am I telling you all these things also? Because you will be having this patient who we need to cool quickly when they come in from a cardiac arrest situation. So you should use these methods to do that. You cannot cool the patient with clothes on top. That is very wrong. You can't cool with the clothes on top. Clothes have to be removed. You can have conductive cooling by putting absolutely cold sheet down the patient, under the patient, because that area is never going to get warm. That is a very large area. Okay, that will never get cool quickly. That's why you require a cold sheet under the patient. So if you have to really do device cooling faster, a cold under the patient will actually make sense. And then comes your invasive or intravascular cooling. The intravascular cooling, when you see, we are giving 4 degrees water, that is 4 degrees normal saline that we have in our fridge. We give 1 liter fast. When you give 1 liter fast, you might drop a degree. So that means to drop 2-3 degrees, you will require 2 to 3 liters. Okay, 1 liter of fluid, of 4 degrees fluid, will drop your temperature by 1 degree. So if you want to drop it from 41 to 38, you will require 3 liters of fluid. Are you understanding? So similarly, when you are dealing with your cardiac arrest patients, you want to cool them down rapidly. Okay, from 37 degrees, you want to get them to 35, approximately 35 to 36. You want to maintain at 36 degrees, 35 to 36. 1 liter of fluid intravascularly will probably be able to do the trick there. Okay, 1 liter of fluid with evaporate. But you as a doctor should understand that if it goes further undershoots, it is going to be a pain to get it back to normalcy. Okay, clear on this? So immersive cooling, very important. Body bag. Then comes evaporative cooling with the spray. Intravascular cooling. The other thing that you can probably help in these cases is to apply a high flow nasal cannula without the humidity. Dry air without humidity. Okay, dry air without humidity, because what will happen as he is breathing, all that air, hot air will just escape out through the high flow nasal cannula. Are you understanding? So you can keep high flow nasal cannula minus humidity. Normally there's humidity on it. Switch off the humidity factor on that. If you don't have that, just put air, not oxygen. Excess oxygen can cause problem. Excess oxygen can cause problem. We don't want to give excess oxygen. So you can probably just put the air on and let the air be on at say 15-20 liters per minute. Okay, that will probably help to evaporate respiratory gases which are hot, normally heat and humidified from inside. It will help to take it out. So if you have a patient even on the ventilator, you can do this. Even on the ventilator, you can just put a high flow nasal cannula or you can put just nasal prongs. But this can't be used for a long time because now you're giving dry air. It's not humidified anymore. So you give dry air 5 to 6 minutes, not more than that. If you go to 10 minutes and 20 minutes and all, maybe 20 minutes and all, there may be a possibility that they'll be drying and bleeding over there. You can't do that for a long time. This is immediate. This is immediate. You understand? So you cannot use it for a very long period of time. And of course, what you normally do in these cases is to monitor your CP case on a regular basis. Every 8 hours, you have to monitor electrolytes because as he's warming, there will be problem. There is going to be changes in electrolytes. There can be hyponatremia, hypernatremia, there can be hypermagnesemia, there can be a lot of things that might come along with these electrolyte imbalances when you have these patients getting rewarmed. Cooled, basically cooled. Now, something very important over here is what happens if the patient gets hypotensive. It's usually going to be fluid. It's going to be fluid related. It's going to be dehydration related, usually. What happens if you give noradrenaline is you will incite vasoconstriction. And if you incite vasoconstriction, again the temperature cannot be dropped. If you vasoconstrict, the temperature cannot be dropped. Are you understanding? So it's a problem. The other thing is, as you're pulling this patient, since you're pulling them fast, there is a possibility that the patient may start shivering. There is a very remote possibility patient may start shivering. If the patient starts shivering, it is very difficult again to pull them down because if they shiver, then the heat will, it's very difficult to pull these patients. Clear? Clear?
Yeah.
So the right thing would be to actually, if the patient is completely altered, having an agitation, having a seizure, intubate this particular patient. Okay, paralyze this patient. Okay, it's important to paralyze, but intubate without giving succinylcholine. This will probably be, if it's malign hypothermia or this, you will not know if you don't know your diagnosis. So you intubate these patients without succinylcholine because otherwise you understand succinylcholine can cause malignant hypothermia, which is also which looks like a heat stroke. Okay, so I would not want to use succinylcholine because I might muddle my diagnosis. Okay, so I will use some other drug, maybe vecuronium or maybe atracurium or rocuronium or something like that. I'll use. I'll intubate my patient here. Okay, and then ensure paralysis for some time because that paralysis will also help you to reduce your shivering. The paralysis will help you to reduce your shivering, reduce your CPK going up and all those things. Okay, and that is the reason that in such patients, intubate, quickly cool, and then they become fine. Then they intubate, quickly cool, and they'll start getting better. Clear? So I hope you've understood heat stroke, which is exertional, non-exertional, what happens with the heat stroke, and how do you treat a patient with heat stroke. Any queries here? Any queries here?
So what do you mean by central fever?
That's completely different.
That's fever.
That's dysautonomia. Say a patient has got a very bad traumatic brain injury, has developed has been operated but probably bled into the brain again. So these patients will have dysautonomia. The autonomic functions of the body are gone around, not working. And so what happens over there? The fever may go up or down. Because that is called as fever originating because from the top. It's not from a peripheral cause like sepsis. It's fever that comes from the top. These patients generally have very poor prognosis. They don't do well. They are patients who are going to remain on the ventilator for longer periods of time. These are those kind of patients. Clear?
Sir, about rhabdomyolysis induced by this heat stroke.
Yeah. Same thing.
Same
The treatment of rhabdomyolysis remains the same that we've always discussed. We've done in the past. Rhabdomyolysis will continue the same. Regular treatment for rhabdomyolysis. No changes here.
The golden hour period, which is they have told that in
Quick.
presentation quick, but what if a patient is found late?
Yeah, we have no option. No? At that time we continue what we're doing.
And prognosis.
Yeah, prognosis is obviously a little bit guarded because if they develop acute pulmonary hepatic failure, they do very badly. They do very badly.
So serotonin syndrome part of heat stroke.
See, there are different causes for a heat stroke. Okay, I would put it this way: if the temperature is more than 104 degrees, one of the cause may be serotonin syndrome, anticholinergic toxicity, salicylate toxicity. A salicylate toxicity can actually cause fever to go more than 104 degrees, and the physiology will remain the same. Because if the fever goes up, there is going to be a problem with respect to the liver. There is going to be a problem with respect to CPK. There is going to be the same thing will probably come in there too. So, but the treatment would be slightly different. Salicylate poisoning, you have to do antidotes for salicylate poisoning. You understand? Anticholinergic toxicity, you will require you require antidotes for anticholinergic toxicity. You understand? Huh? Like for example, if your organophosphorus, atropine poisoning, you will require antidotes for atropine poisoning, but the physiology will remain the same. So, if you ask me, there are various reasons for the temperature being more than 104 degrees, but to qualify for a heat stroke clinically, you require the temperature to be plus. Apart from that, you need altered mental status, maybe a seizure or something like that comes in along with the heat stroke to actually call it a heat stroke. It's like an umbrella term for everything else. What you should understand is the physiology remains the same. Okay, we need to take care of everything with respect to what we just thought about. So when you intubate these patients, few things is in an emergency is you don't intubate with succinylcholine. You try to give them a paralytic agent for a longer period of time, and you keep them sedated. You keep them sedated. Even if the patient is non-intubated, keep them sedated. Even if the patient is non-intubated, keep them sedated. Okay, keep them sedated with ketamine, keep them sedated with benzodiazepines, keep them sedated with something like that. You may want to avoid an opioid, but you want to do all these things because more the agitation, more the heat dissipation, more the heat stroke, more the patient gets warmer. Okay, so we want the patient to be calm. That's why we want to ensure that we put some sedation on board when we are treating these patients. Clear?